Learning objectives for the examination of the thorax and the lungs are to review the anatomy and physiology of the thorax and the lungs. Secondly, to apply proper and correct techniques in order so that the examination of the posterior and anterior chest, including palpation, percussion, and auscultation, will be correct. Some of the common or concerning symptoms to look forward for are chest pain, dyspnea or shortness of breath, wheezing, cough, and hemoptysis, that is the availability of blood in the sputum. Now, when it comes to the organ lung and its associated counseling, the most common habit perpetuating the destruction of lungs is smoking. We are supposed to counsel the smokers while doing the examination of the thorax. We should keep some important landmarks in mind. The bony thorax covers the organs such as the heart and lungs, and also partially covers livers, kidney, and spleen. The thorax contains 12 pairs of ribs attached to the sternum through the costal cartilage anteriorly and posteriorly to the thoracic vertebrae. Now, inferiorly, the anterior cartilage and ribs form the right and left costal margin. We should keep this in mind that while examining the patient, we shall be able to determine and differentiate all the 12 ribs and their interspaces. Now, while beginning with the anterior part, we shall begin with finding the sternal angle. While doing this, we shall first place our finger in the suprasternal notch, then slide our fingers downwards 5 cm unless and until we can feel the bony ridge that joins the manubrium and the sternum. Now, this is the sternal angle. After this, we shall find the adjacent second rib and costal cartilages moving sideways. Now, on the posterior aspect, the 12th rib is starting point for the counting of the ribs and adjacent interspaces. Now, the inferior angle of scapula is also a bony landmark which lies along the 7th rib or 7th interspace. The method for counting the ribs is to count down from the C7 process. Now, while starting from C7, the technique is we should ask the patient to lower their chin to their chest. Now, with the neck flexed forward, we shall find the most prominent structure or spinous process sticking out, which is the C7. Then feel and count from the C7 to T12. We can usually palpate processes when spine is flexed. Now, while stating our findings anteriorly, we shall use these reference lines such as the anterior axillary line, mid-sternal line, mid-clavicular line, mid-axillary line, and a posterior axillary line. Anteriorly, we shall use references such as the vertebral line and the scapular line. Forward, while examining the chest, we shall remember the points such as the apex of the lung, which is 2 to 3 cm above the clavicle, the lower border of the lung, which is at the position of the 6th rib at the mid-clavicular line, and the 8th rib at the mid-axillary line. Posteriorly, the border of the lung lies at the T10 spinous process. On inspiration, it descends 3 to 5 cm downwards. Coming towards the lungs, each lung is divided into half by an oblique or a major fissure. The right lung is divided into the upper, middle, and the lower lobes, and the left lung is divided into 2 lobes. Now, while doing the examination, we should be aware of some general anatomical terms. Those are supraclavicular, that is above the clavicles, infraclavicular, that is below the clavicles, interscapular, that is between the scapulae, and infrascapular, that is below the scapula. Now, while coming towards the trachea divides into the main left and right bronchus at the sternal angle anteriorly and the T4 spinous process posteriorly. While coming towards the physical examination, we shall begin with the brief survey of the patient's thorax and the respiration. Note the shape and movement of the chest, if it is symmetrical or if there is any bony deformity. Now, observe the rate, rhythm, and if there is any obstructive or distressful sound from the patient while he breathes. After this, we shall wait patiently and count the number of breaths the patient takes per minute. The normal range is 14 to 20 normal relaxed breaths in a normal relaxed adult. Also inspect the neck for muscle retraction. Example, the supraclavicular muscle, sternocleidomastoid muscle, and the scalene. If there is any retraction, it suggests respiratory difficulties. Now, palpate in the sternal notch for the position of the trachea, which should be in the midline. Also, check the patient's finger or nail beds for cyanosis, and also the lips, as normally the nail beds and the lips are pink, but during cyanosis they become pale or a bluish tinge. Posteriorly for the chest, we shall look for the contour, symmetry and deformity and also inspect the overlying skin. We shall look for bruises or fractures if any. For checking for the chest expansion, place the thumbs close to patient's spine at the level of 10th rib and other fingers against lateral thorax. Now ask the patient to inhale and exhale fully and observe the divergence of our thumbs and feel for range and symmetry of the movement. Decreased movement suggests lung deformity. Palpate for the tactile fremitus. Ask the patient to say 99 over and over again. Feel for the vibrations using the ball of our hand or the ulnar surface. Palpate different locations for increased, decreased or absent fremitus.
Okay, now I am going to check your tactile fremitus, which is a noise or a vibration coming from you when you say a word. So I would like you to say 99 over and over again. Okay?
Okay.
1, 2, 3, start.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
And the note sense of vibration. While doing the percussions, our tapping wrist should be relaxed. Only the flexor finger should be tapping on the pleximeter finger of the relaxed hand. Nextly, ask the patient to breathe out. Now ask the person to breathe out and with the help of percussion, get to know about the lower levels of the diaphragm. Now ask the patient to inhale fully and with the help of the percussion, get to know about the diaphragmatic excursion. The excursion is usually 3 to 5 centimeters. Now coming towards the auscultation, which is the most important technique for knowing about the airflow. This technique involves listening to the sound that is generated by breathing, if there are any adventitious sounds or if there is abnormalities while the patient speaks or through a whispered voice. To auscultate the posterior thorax, use the diaphragm of the stethoscope and auscultate the apices first. Then move downwards and systematically move side to side, thus comparing breath sounds in symmetrical areas. Listen to the duration, pitch and intensity while the patient inspires fully and expires fully. We should make a note about what type of breath sounds we are listening to. We should make a special note if there is inspiration and heard over most of the lung fields. The bronchial breath sounds on the other hand are harsher, louder and higher in pitch. They are heard over trachea and over the mainstem bronchi. The expiratory sounds last longer than inspiratory sounds and a silent gap may separate these sounds. Talking about the bronchovesicular sounds, they are heard in the first and second interspaces anteriorly and also between the scapulae posteriorly. They have an intermediate pitch and intensity and the inspiratory and expiratory sounds equal in duration and sound separated by silent interval. Now the adventitious or added breath sounds are superimposed or duplicated on the usual breath sound. To detect these sounds is one of the important goals of our examination. Often leads us to cardiac or pulmonary conditions if there are any. This sound includes crackles or ralls and also wheezes and rhonchi. Description about the crackles are they are intermittent, non-musical and are brief in time and often heard in pneumonia, pulmonary fibrosis and early heart failure. While the coarse crackles are louder, lower pitched and longer. While we compare the crackles or ralls to wheezes and rhonchi last much longer and they sound in a tone or in a musical tone. Wheezes are very common in asthmatic patient. They have a hissing or shrill quality and are very high pitched, whereas rhonchi or rhonchi are lower pitched and have a snoring quality. They arise from the secretions in the large airways